Hello everyone. Last time we learned about water and the sodium metabolism disorder, and today we will proceed to the potassium metabolism disorders. Section 3: Potassium metabolism disorder. Characteristics of normal potassium metabolism. Content and distribution of potassium in body. Total potassium content 50 to 55 millimole per kilogram. Specifically, 90% in cells, 2.6% in bones, 1% in transcellular fluid, 1.4% in extracellular fluid. Source of potassium: intake of 50 to 200 millimole per liter per day. All animal and plant cells are rich in potassium, and 90% are observed by small intestine. Potassium excretion: 90% of kidneys regulated by aldosterone, 10% by intestinal tract and perspiration. Potassium characteristic: more intake, more excretion; less intake, less excretion; no intake, yet excretion. Now, let's study hypokalemia. When serum potassium concentration is lower than 2.5 millimole per liter, we call it hypokalemia. 1. Etiology. Number 1. Inefficient intake of food for a long time. 2. Excessive excretion of potassium for a kidney due to application of diuretic, renal tubular acidosis, diuretic phases of acute renal failure, and excessive mineralocorticoid, aldosterone. 3. Patients receive liquid without potassium salt for a long time, or inefficient potassium salt in peritoneal nutrient solution. 4. Potassium loss from extrarenal route due to vomit, persistent gastrointestinal decompression, and intestinal fistula. 5. Transfer of potassium in case of large infusion of glucose, insulin, or metabolic alkalosis and respiratory alkalosis. Persistent hypomedia often indicates a significant lack of potassium in the body. 2. Clinical manifestations. 1. The earliest clinical manifestations is muscle weakness, starting with limbs and spreading to torso and the reciprocal muscles, which may lead to dyspnea, asphyxia upon respiratory muscle tiredness. Another manifestations are flaccid, paralyzed, tendon reflexes diminish or disappear. 2. Patients show the symptoms of anorexia, nausea, vomiting, abdominal distension, intraanalyze. 3. Heart involvement is mainly manifested by nodal tachycardia, conduction block, and alloarrhythmia. Typical ECG changes are earlier T-wave reduction, flattering of invasion, followed by ST segment reduction, prolongation of QT interval, and U-wave. 4. Metabolic alkalosis and the paradoxic acid rule. Potassium ion is removed from cells and its exchange with sodium ion and hydrogen is increased. Upon removal of every 3 potassium ion, 2 sodium ion and 1 hydrogen are transferred into cells, which decrease the concentration of hydrogen in extracellular fluid. On the other hand, the sodium ion and potassium ion exchanges in distal convoluted renal tuber decreased, while sodium ion and hydrogen exchanges increased, thus increasing the hydrogen drainage. Both of these effects can lead to hypertonic alkalosis in patients, whereas Buryum is acidic. 3. Diagnose. 1. Medical history and clinical manifestations. 2. Blood potassium ion less than 2.5 millimole per liter. 3. ACG changed as an auxiliary diagnose. 4. Treatment. 1. Eliminate the etiology, and it is a priority to do. 2. Supplement potassium ion. Mild. Encourage intake of food rich in potassium or oral administration of potassium chloride. Intravenously supply to patient who is unable to eat. There are some tips as followed. 1. Intravenous injection is prohibited. 2. Amount daily supplement of 40 to 80 millimole potassium. Daily supplement of 3 to 6 grams potassium chloride. Concentration and speed. Potassium content in every 1,000 milliliter fluid should not exceed 40 millimole, equivalent to 3 grams potassium chloride. 3. Infusion speed is controlled below 20 millimole per hour, equivalent to potassium chloride at 1.5 grams per hour. 4. Supplement potassium upon urination. Supplement potassium when urine volume over 40 mm per hour. 3. Correct water and other electrolyte metabolism disorder, alkalosis, and low chloride. When blood potassium concentration is higher than 5.5 millimole per liter, we call it as hyperkalemia. 1. Etiology. 1. Excessive intake of potassium. 2. Reduction of potassium excretion, renal failure, and inefficiency of arterial contact function. 3. Excessive excretion of potassium in cell. 1. Acidosis. 2. Damage and destruction of cells and tissues, such as intravascular and hemolysis. Severe trauma, especially crash syndrome. 2. Clinical manifestations. 1. Non-specific clinical symptoms, blurred mind, abnormal feeling, and limbs weakness may occur. And clinical manifestations of microcirculation disturbance may occur for a case of severe hypokalemia. 2. Frequent bradycardia or arrhythmia. Most consequences sudden cardiac arrest. 3. Typical ECG changes are high and sharp earlier T wave and QT interval prolongation, followed by QRS broadening and PR interval prolongation. 3. Diagnose. 1. Medical history and clinical manifestations. 2. The most important is blood potassium over 5.5 millimole per liter. 3. An ECG change as an auxiliary diagnose. 4. Treatment. 1. Stop all potassium-containing drugs. 2. Decrease the concentration of serum potassium. Infusion of 5% sodium bicarbonate solution. Infusion of dextrose solution and insulin. 24-hour intravenous perfusion of 100 mm of 10% calcium gluconate, 15 mm of 11.2% sodium lactate solution, and 400 ml of 25% glucose solution. Add into 20 urine insulin for a patient with renal dysfunction. 2. Application of cation exchange resin. Potassium ion can be extracted from the digestive tract. 3. Diuretics such as furosemide, which promotes the potassium to be extracted from kidney, yet its effect is not satisfying for a patient with renal dysfunction. 4. Dialysis, suitable for a patient with invalid treatment effect of the above theories or suffering severe hyperkalemia. 3. Antiarrhythmia. Slow intravenous infusion of 10 to 20 millimeters of 10% calcium gluconate after dilation. Today's lesson is over. See you next lesson.